Edward Ungar, co-founder and CEO of Pharmaciège. We all very welcome. Thank you very much indeed. We'll hear from somebody now who's founded something that is successful.
Well, thank you, Lord Gaelica, for the kind introduction. And also thank you to Annette and Josie and Mark and Paul and Julian and everyone at the De Walden who's put this on. I think this is a fantastic event. I'm Edward Ungar. I'm co-founder and CEO of Pharmaciège, a slightly awkward elision of pharmacy and concierge, if you hadn't worked it out already. And this is our reception area as a backdrop. We create e-prescription tech for private doctors, and those apps that they use allow them to offer a private prescription delivery experience that's very seamless for their patients. That's the what we do. What I am definitely not, and very conscious of in the eminent company that I'm keeping today, is I'm not an expert on how innovation has been challenged or overcome in the NHS. What I will hope to do, however, is maybe give, for those of you who don't know as much about pharmacy in the private market, and some context from the NHS as to how we are driving innovation in a slightly different way, in a slightly different space. But I'm going to go out on a limb, say something bold. I don't think it's heresy, but to say that the challenges facing innovation in healthcare, I don't think are unique to healthcare. I'm on my fifth industry, and I've seen all of these challenges in other industries before. The difference in healthcare, as my 7 years have taught me, is that those challenges are often dialed up to 11 by the affiliated risks that come with just working in healthcare as a whole. If I dial back to my previous industry, which is identity verification, if the machine learning algorithm and computer vision learning tech didn't work properly, the worst that would happen is we wouldn't spot a really sophisticated fake passport. Nobody went to jail for that. Nobody was hauled up before a regulator, at least not yet in compliance teams. The jury is out. And of course, there was no comorbidities or worse than that, mortality. In healthcare and in pharmacy, if a doctor were to choose a technology which is unregulated, uninspected, uninsurable, cheaply developed and poorly protected, it would be on them that they chose that. And should that technology conflate two drugs together and a patient came to harm, there would be questions asked by the GMC, doubtless, as to why they'd made the choice and due diligence that they made. So there are very serious consequences in healthcare to not approaching these challenges appropriately, which weren't there in some of my advertising and financial journalism days, or at Google even though those companies had regulatory hurdles to get over. So we as a company decided that many of those challenges were not ours to overcome. And funding, yes, is a challenge we had to overcome, but it's not something that we could influence as an industry. Regulation, we had to accept. Private pharmacy is subject to exactly the same regulations as NHS pharmacy, and the scrutiny is as direct, if not even more so. And data privacy, we're all subject to the same rules, and we have to protect the populations, both the clinicians, for the clinician's sake and for the patient's sake, as everyone else. So we put our focus and our energy into overcoming the barriers that we foresaw in technical infrastructure to making this work better for clinicians, and also in the clinician's own resistance to change, which for the clinicians in the room, I'll talk about a little later, but also in the adoption by this kind of technology and the acceptance of it by patients, which is the other side of the equation, even if they're recommended it by their clinician. A quick history, for those who are not as familiar, of pharmacy in the NHS and technology adoption. The NHS moved towards what you now know as EPS in 2005. That was a great leap forward. It was a very expensive leap forward. Somebody in the room probably knows how expensive. It was probably in the tens of billions at an estimate. And it had to do a lot of things for a lot of people, so no question it needed to be. But there were 15 or 16 years before 2021 when the sort of excellent improvements in adoption of that technology was then brought forward into the app, where you could order repeat prescriptions, etc., from your mobile phone. We, by contrast, we weren't as quick to electronic prescriptions. We're a co-founded team of brothers, and my brother actually pioneered the first electronic prescription in the private market in approximately around 2010. And we actually also launched our mobile-only private prescriptions on Apple and Android app in 2021. So it gives you a sense that we probably didn't spend 10 billion. To create the app, we raised some money in 2020 when we realized the pandemic was upon us. We raised 1.25 million initially. And with that, we created the app. Now, it's not because you needed to spend 10 billion, it's because what we were focusing on was much, much narrower, of course, than what the NHS was trying to do. We were trying to improve the lot of private clinicians, save them time, increase their productivity, give them more time back to spend with their patients. And I hosted an eminent neurologist who I was giving a tour to yesterday in our premises, which, by the way, are just up the street. We have approximately 60 people further up Wimpole Street at the corner with Weymouth Street. And he said, and I called out to our product manager who was within earshot, he said, of his own accord, he said, "Your app changed my life." I didn't ask him to come out with that, because he can now receive a request for a repeat prescription from his case, can be a migraine or Parkinson's patient. And by the time, in his words, he's crossed the room, he's found the patient in our app, re-prescribed or prescribed something new for that patient, and known that it's gone to a safe home, which will be correctly handled through all the correct regulations, and then dispatched, as it happens, out of Wimpole Street to the patient wherever they are in the country. And that is really the eureka moment, is for the clinician, oh, this is better. That's the trick to adoption. And it's one that we still have yet to get a lot of clinicians over the hump of. So when I use the NHS here, I'm really just using it as a context within which to put how we've approached that innovation. So with the NHS pathway, you get interoperability with other existing systems. You get tie-in to GPs. You get tie-in to hospitals and secondary care. So to an extent, you get some guaranteed adoption. I recognize that it's not as full-throated as it could be, but you get some guaranteed adoption. The notion that build it and they will come can actually be true when it comes to systems the NHS invests in, like the EPS. Whereas in private, you have to do all the work through decentralized partnerships and APIs. Your sales are more classic. They have to work through word of mouth between people in the industry and through traditional sales and marketing. Funding comes either from central government or from trusts, whereas for us, we never, probably should have approached Innovate UK, but never believed that a government funding would necessarily come the way of private medicine and private pharmacy. So we bootstrapped for the first approximately 10 to 15 years, really, and only took money when the pandemic was upon us, and we realized that if we were going to survive that wave of increased adoption, we were going to have to innovate, and that was going to require more than organic funding. So we took investment then. I'll talk about that in a second. Regulatory support. In theory, the NHS can actually change the regulation. We don't have that luxury, and therefore we navigate within regulatory boundaries. We're subject, as I say, to all of exactly the same regulations that the NHS is, and when we were inspected in August, just up the way here, the inspector went into huge areas of detail that I don't think they would have necessarily done, because what we are doing is slightly different, and was very satisfied with the answers that they got back, because they were within the same regulatory frameworks that the GPHC, who's our regulator, understood. Data security, it's the same for all players on both sides of the equation, whether public or private, but we, of course, have a smaller pond to defend than the tens of thousands, if not millions of users that the NHS has. So what does it give us? The flexibility, let's say, outside of the NHS constraints. We can launch and iterate, just as the big tech firms, the Amazons, Googles, and Microsofts of the world do. And we have rapid version development that's under our own control. We also control the entire ERP, which is the Enterprise Resource Planning tech behind that sits behind our technology that manages the workflow. And that allows us to have a laser focus on clinicians and what they need and what they want to save time doing, but also on the workflow as adjusted for, and I say adjusted for rather than changed, for the private market and logistics of delivery, which many pharmacies don't have the burden of dealing with for as high a percentage as we do. And finally, a focus on the consumer, making their experience of just receiving a text message and or an email and paying for their medicine with Google Pay and Apple Pay and in a much more, I hesitate to call it an Amazon experience, but let's say a Google, Amazon, Microsoft experience rather than having to fill in their complete details each time. And that we have convenient delivery and real-time tracking for the clinicians so that they know what the patient's compliance is like and how we are doing to fulfill for their patient. So again, by contrast, coming back to the funding aspect, we don't take a dime from the Department of Health or from the NHS. Pharmacy in the UK is actually one of the largest public-private partnerships that exist, but the public don't perceive it that way because it seems like it's a small private business, but actually their main client in most cases is the NHS subsidy. Whereas our approach was, we had been around for quite a long time, so there were people who knew what we did, they understood the product, and doctors actually approached us and said, well, can we invest in you because we like what you're doing? And that turned into a strategy which started with about 25 investors in 2020 and is now up to 85 doctors who have invested and a very broad mixture of primary and secondary clinicians just across every aspect of the huge spectrum of drugs that we do across so many specialisms. In there are former founders, in there are venture capitalists talking to the community who have actually, in our case, invested their own money rather than their fund's money. Make of that what you will. So the probably toughest challenge to overcome in innovation is actually, as others have mentioned, is the resistance to change, even in the private market, or perhaps especially in the private market when nobody's telling them what they have to use, nobody's telling doctors what they need to do. So we have, over the years, overcome people who I affectionately call career handwriters when it comes to prescriptions, others who have been printing them and sending them by email or fax, which for a long time was the only technology that was available. But just to be clear, an electronic signature on a prescription that is then emailed through to a pharmacy is not an electronic prescription. That is a facsimile prescription on a PDF. It's not legally valid. And in order to create a proper electronic prescription, you have to follow the rules of European and UK e-prescription technology, which say there has to be various pillars involved in that, which include a password or, in our case, a passcode that only a clinician knows, which is much more similar to the NHS key and PIN that you need to use in order to prescribe. So our prescribers, and this is not a stock image, this is one of our eminent rheumatologists, Dr. Elisa Ristori, using our app. And that eureka moment is very much how the innovation is perceived by the clinician. But it's not just digital workflows and digital processes that we needed to innovate on. Everyone's familiar with, you walk up to a pharmacy, you walk in a front door, there's usually a dispensary, it's often at the back, there's a relatively cramped space in which a small number of people are working, and that's the physical workflow that they have to deal with, because most of those medicines that they're putting together are then put on a shelf and wait for the patient to show up and collect. So in order to deliver what we needed to do along between the private pathway and the delivery aspect is we needed to completely reinvent how a pharmacy looks and operates to match the digital workflow that we'd created. So on the right, you see a cutaway image. Obviously, this is a digitally generated image. We can't see through floors, but this is exactly what the premises looks like. There's a very a very beautiful reception on the top right, where about 1 or 2% of our patients ever come to collect or drop off. But the vast majority, 98-ish percent, is operating behind the scenes, behind that reception. And that plain white box is a robot I'll come on to in a minute. You caught a glimpse of it, by the way, in the Howard Warden video that they showed at the beginning. And it has 6 concurrent exit chutes, which are the grey pipes coming out of it, which go down through gravity into a set of spirals in the basement, where we can have then 6, it's actually closer to 8, concurrent assembly points for the prescriptions that are coming through from private clinicians. And what you can't see is that it then goes back and back through to the Weymouth Street, Wimpole Street junction, where the rest of the workflow snakes through and comes out, emerges at the other side at the Weymouth Street corner in an exit that is purely used by and restricted, data restricted to the couriers, so they can't get into the rest of the premises. So it isn't just about software, it's about actually changing the physical environment. The premises beforehand were a pathology lab, private pathology lab primarily, and therefore weren't set up or designed for the purpose. We got a pharmacy designer in who's designed 500 pharmacies around the world, and even he hadn't done the upstairs-downstairs approach to robotics and medicines dropping through the floor before. And it was an exercise in matching our digital workflow to the physical environment. So the robot you saw in the De Walden video before, this is it. Again, not a stock image. This is what it actually looks like. It's 30 feet long, contains up to about 15,000 or so packs, and it's all packs. It's not individual tablets that you'll have in some of the rest of the private estate. We think this is certainly the largest of its kind in central London, if not in London for packets. And it uses what is called chaotic storage, and that is the key, which is that no human would understand how these drugs are recognized, and I don't know where any of them are, and neither do my team. And that's not nerve-wracking. And the reason it's not nerve-wracking is because the chaotic storage, the machine learning-driven model, mean that it's optimizing for the huge range of medicines that we do. We could never do this with, well, we did used to do it with humans. I sometimes struggle to remember how now. But because we have 6,500 to 7,000 different medication lines over the course of maybe a 2-year period, which to put in context is probably 5 to 10x of what a typical pharmacy would do due to the range of specialisms we support. You can't do that with a human brain. It just isn't possible. These medicines are stacked 3 deep. They are determined in their position by, yes, their size and which shelf they go on, but they're also determined by what frequency of use they have and their distance from the 6 exit chutes, which are the grey boxes down the left, and how often they're used. So even the best mathematical boffin wouldn't be able to square that circle. So it was inevitably next, and how we integrated it to the workflow was the biggest challenge. We also had to rethink the consumer experience. As I say, very few people end up in a queue in our premises. The way pharmacy works typically is, if you get a private prescription, you take it to the pharmacy, you queue first, if there is one. You get to the front, you find out, do they have it, do they not have it? If they don't have it, you'll then have to hand the prescription in, pay for it, go away, come back when they've got it, and then queue again. It's not the most seamless experience for the private patient, particularly if they're infirm or, frankly, looking for a med that is not commonly available throughout the standard NHS private pharmacy estate. So our focus is 98% on delivery. Again, not a stock image. That is my 2-year-old and my wife. But the principle is that when you do have a baby under your arm, queuing in a pharmacy is not really what is going to take your fancy. And the final ingredient X in innovation we have found is people. Possibly an obvious thing to say, but this is our team outside in Weymouth Street. It's not just the software developers and the programmers and the product managers who have the say on our technology and our workflow. You have to hire people who are willing to step up and say, actually, I think this could work better. And the joy, if you like, of the entrepreneurial joy is we do then have the self-determination to change the workflow in order to deliver a better result for the team. And that's hugely empowering for them. They're all, by the way, shareholders. And the other beauty of the private market is we can give them shares in the business. So they do feel a sense of ownership. We fortunately did that in January 2020. You know what happens next. And given what we then required of them and the PTSD-inducing experience that everyone in frontline healthcare went through, I'm so glad and grateful that we did give them the ownership at that point. So I hope that's been a useful counterpoint, perhaps, to some of the NHS discussion. Very happy to take questions.
The Harley Street Health District, the home of healthcare since 1860.